Perfect. Hello, everyone, and welcome. Before we get started and Michaela introduces our speaker for the evening, just a few housekeeping items as we begin. First of all, USD students, enjoy your day off tomorrow. I know some disciplines don't have the day off, but be safe and stay warm as this winter weather goes through. If you have time and need to submit your hours, please do so as soon as possible. Michaela and I have a report here due in about 2 weeks, and we'd like to have updated hours submitted to our funding agency. So if you could kindly update your hours in the classroom, that would be much appreciated. The next one is our March Scholar session is still in the works. Michaela and I are trying to decide if we want to do a documentary screening like we did last year, or utilize a different speaker that we have some access to kind of in a different landscape. So we'll keep you posted as that keeps furthering, I guess, development. Otherwise, it's just your hours, get those in. Also, if you want to recruit any of your classmates or your cohort, please do so. Michaela and I are doing a drawing for our new registrants or new applicants. So if you convince a couple people or even just a friend apply for scholars and they're interested, we'd be more than happy to reward you with that. And then we'll also be doing a drawing here in the next couple weeks for those who submit their hours. And we'll send this in an email as well. So Michaela, are there any other housekeeping? It was pretty much just stay safe and warm, submit your hours, and recruit your friends, right?
Yes. Yep.
Perfect. I will turn it over to you to introduce our speaker for this evening.
Yes. We are excited to have Christine Becker from Avera Health speak to you guys today about telehealth. So I will pass it over to you, Christine.
Thanks, Michaela. I'm going to go ahead and share my screen here. Sorry. All right, now I'm sharing my screen. So thanks for having me tonight and letting me talk a little bit about telehealth. This is a topic I'm pretty passionate about in my role at Avera Health. So I've been with Avera for about 17 years. I started my career at Avera working in clinics, working with providers and clinic staff, really helping improve workflows and efficiencies, and ultimately provider satisfaction. That was the purpose behind the program that I was working with. But that was at the time in healthcare where we were just starting to implement the electronic medical record. And so my career and my focus on workflows and efficiency really morphed over the first few years I was at Avera, because Avera started to implement the electronic medical record in the clinic. And that was brand new. We were going at the time from paper charts to an electronic medical record, and it shook everybody's world. It was a whole new way to practice, not necessarily to practice medicine, but to run the clinic and to see the patients. And so I spent, a good 15 years at Avera working in that EMR kind of space. But within the past year, I've moved into a role focused on telehealth. And telehealth has been around a long time, especially at Avera. But the way we're using telehealth and the technologies that are available to us now are really going to change, healthcare, just like the electronic medical record did, 15, 20 years ago. And so just a little bit about Avera. Avera is a Catholic health system that was founded by the Benedictine Sisters in Yankton, South Dakota, and the Presentation Sisters in Aberdeen. And Avera is a health ministry whose mission is to make a positive impact on the lives and health of the persons and communities by providing quality services guided by Christian values. And to support our mission, we have three guiding principles that we follow, and they are compassion, hospitality, and stewardship. And when I think about Avera's mission and our values, those are all of the reasons why we do telehealth, especially in our rural areas, is to really support our ministry and to provide care in areas where they might not have access to the same care that we have in urban centers. So Avera's footprint crosses a 5-state area. We're in North Dakota, South Dakota, Minnesota, Iowa, and Nebraska. We have over 315 locations in 100 different communities. We serve a population of over 1 million people, But those 1 million people are spread across 72,000 square miles. That's a lot of geographic area for us to focus on. So another reason why telehealth is so important for a health system like Avera, in our footprint in this part of the country where we live. I'm going to take you back in time a little bit, back to the 1960s. There was a cartoon that was produced. This was way before, I'm sure, all of your time, but it was called The Jetsons. I'm not sure if any of you have heard of the Jetsons cartoon, but the Jetsons was a space-age cartoon that was meant to be the counterpart to the Flintstones, if you know the Flintstones, which was a prehistoric family. And so in the Jetson cartoon, it was set in the year 2062, and it was about the life of George Jetson and his wife, Judy, and they had a couple of kids, and they had a robot and a flying car. So they were very space age. They had a lot of really, at the time, far out technologies that they used. And, while the flying cars haven't come to fruition, a lot of the other technologies have. And a couple of the technologies that we see from the show that are used today are really related to telehealth. And so in the Jetsons, this was way back in 1962, they had, George Jetson had this fancy watch, a smartwatch. And on his watch, he could do video calls. The smartwatch would collect data about where he was and what he was doing. And in the Jetsons, the cartoon, the watch was often used for his boss to catch him when he wasn't doing work, when he should have been doing work, and then the boss would yell at him. But another way they used telehealth in the Jetsons was this kind of concept here. This is the wife, Judy. Her son, Elroy was his name, was sick one day. And so she walks over to her wall, on the side of her house, and she pushes a button for emergency first aid. And when she pushes that button, down comes the doctor on a TV screen, and the doctor is able to diagnose Elroy with something called the venous virus, and Elroy is able to stay home from school. So that was how the Jetsons in 1962, how they envisioned healthcare and what they thought healthcare would look like in the year 2062. Well, here we are now in the 2020s, and healthcare isn't just for the Jetsons anymore. The American Medical Association has said that virtual care or telehealth is now part of the U.S. healthcare system. It provides access to patients for high quality care, and it strengthens the continuity of care way past the COVID-19 pandemic. The AMA also states that telehealth really serves many underserved communities that historically have not had access to care. And these underserved communities can now beam in the additional support they need for their workforce, as well as have access to the top specialists to help save lives and treat critically ill patients. And that's really what telehealth is all about. Telehealth isn't a specific service. It's not a specific tool. Rather, it's a variety of tools and services that really allow us to provide care to our patients from a distance. There's all different kinds of telehealth, and I'll talk about several of them as we go through today. But I want to highlight a couple of them that I really want to call out as we go through the talk today. But our telehealth systems are used in all of our different care settings at Avera and at health systems all across the country. They're used in the inpatient world, outpatient world, emergency, urgent care, long-term care. We use healthcare to reach out to or telehealth to reach out to our schools. We use telehealth to reach out to prisons. Anywhere where there's healthcare, there's likely to be telehealth. Telehealth really provides us the ability to get healthcare where it's needed, when it's needed. So as I go through the presentation today, I didn't talk about this in the beginning, but feel free to take yourself off mute and ask questions or put them in chat. I'm happy to answer them as we go through the presentation today. So healthcare at Avera started in the 1990s, and it started really because of need. We had to be innovative, and we had to find solutions to address some of the challenges that we were faced with. And those challenges actually are some of the same challenges we see today. Challenges like we have a shrinking margin all the time in healthcare. It's always a shrinking margin. We have increased regulations We have workforce challenges, both with our physicians being able to recruit physicians, both in primary care and specialty care, to our facilities, especially in our rural areas. That's a constant challenge. We are faced right now with a nursing challenge that is, unprecedented. We are really challenged to find nurses, not only to staff in our urban areas, but in our rural areas. We're challenged to keep nurses. All clinicians are facing a lot of burnout, and those were the same challenges that faced us in the 1990s when we first started to implement telehealth. And the idea behind telehealth was not only to care for our patients, but also to address some of those challenges that I mentioned. Take us forward 30 years, we're in 2022 last year. Avera does a lot of telehealth. Last year, we had nearly 500,000 telehealth interactions across our healthcare system. One of the areas of telehealth that has grown, and this will be very obvious to you during the pandemic, was virtual visits. And virtual visits are the visits patients have with their provider, just a video visit where the patient may be at home or at work and they're calling the provider on their phone and having that video visit. Prior to the pandemic, we didn't do very many of them at all, maybe a handful here and there. On March of 2020, we went from basically doing next to zero virtual visits to nearly doing 60% of all of our visits virtually. We had to, ramp up overnight, and for several months, because patients couldn't come into the clinic, most of our visits were done virtually. And with all of that, and with that change, we realized that we can provide good quality care through virtual visits. Patients do like access to that flexibility. And so we've really worked to try to find ways to keep this embedded within our toolkit and within our workflow within Avera. So I'm going to highlight a couple of the different telehealth services that we use across Avera. One of them is called eEmergency. And eEmergency is a service that we offer in many of our rural facilities, and we partner with Avel eCare to offer this service. And in many of our rural hospitals, there is not a physician in the emergency room 24/7. Rather, they are called in when and if they're needed. So typically in an emergency room in these rural facilities, they're staffed by nurses, and the nurses are there caring for patients, and they'll call the physician in when needed. And so I'm going to take you back to a few years ago in one of our rural facilities where it was one of these situations where the nurse was staffing the ER, and the nurse got a call from the ambulance service saying that they had a patient that was en route that had been severely injured from a hunting accident. He had severe wounds, and they were about 20 minutes out. And so the nurse immediately calls the physician on call, who is also about 20 minutes out from the hospital. The physician comes in and arrives there basically at the same time the patient is arriving. So when the physician gets there, he realizes that this man who's severely injured is somebody he knows. It's a close friend of his, which happens a lot in these small communities. And so this physician is faced with trying to care for this man with very severe injuries, knowing that this man is a close friend. This physician is also alone. He is the only physician in the facility. He realizes that this patient needs more care or more expertise than he can provide. So he walks over the wall and presses that emergency button, just similar to what Judy Jetson did to get that doctor to kind of beam into her futuristic house. So the doctor presses the emergency button, and within 20 seconds, that physician is connected with one of the ER physicians in the emergency hub. And that emergency physician is located in Sioux Falls in this example, and about 200 miles away from where this patient and where this provider was. But those two physicians cared for that patient for several hours, saving his life. And when the doctor finally went home from the hospital that night, he commented to the nurse that this was the first time in his 20 years of practicing medicine that he wasn't going home wondering, did he do enough for the patient? Did he do the right things for the patient? Did he make the right decisions for the patient? He said telemedicine had given him peace of mind, and telemedicine had given him virtually the team that he needed to save this patient's life. That's a really powerful statement, not only in being able to care for that patient and save that patient's life, but also in the quality of life for that physician, knowing that he wasn't alone, that he had the resources he needed. That has extended that career for that physician. It's also enabled, this service has also enabled us to help recruit physicians to some of these rural communities, because they too will have the support of those emergency physicians and nurses when they need it for one of those situations. Another telehealth service I want to highlight is something we call eRADOC, and this is related to radiation oncology. And so as part of Avera's mission, we are to provide equal access to healthcare services regardless of where the patient lives, whether they live in an urban area or a rural area. So to help meet that need, we have 6 cancer centers across Avera, and that allows patients to get their radiation treatments close to home, right? They don't have to make the trip to Sioux Falls. However, in order to provide radiation oncology, you need a radiation oncologist, and they're hard to come by. That's a specialty that's very much in demand, and those specialists tend to be in urban areas, or that's where they tend to want to work, in urban areas. So we were faced several years ago with a challenge about how do we continue to provide radiation oncology services for our patients across our 72,000-mile footprint in our 6 cancer centers when we don't have radiation oncologists to put in each of those cancer centers. That is how the eRadiation Oncology program was started. And what this program involves is technology, basically cameras, speakers, microphones, monitors, things like that, that allows the radiation oncologist to be a part of all of the patient's planning and care delivery remotely. So for example, one of the first steps with radiation treatment is a CT simulation, where the patient, goes through a CT scan kind of process. So the local staff, in conjunction with the radiation oncologist, can determine exactly where that radiation should be delivered. And that requires a lot of planning and a lot of, sort of exact science. Through the technology that we have, the provider can join that local radiation therapist remotely and be a part of that whole process. The next step in the process is really the radiation planning, to where the dosimetrist and the radiation oncologist get together, review all the data, and make the radiation plan. That too can now happen remotely, where they can join virtually to do all of that planning. But probably the most impactful part of eRadiation oncology is when it comes time to actually deliver the radiation treatments. Radiation treatments often need to be delivered multiple days in a row, 3, 4, 5 days in a row for several weeks. So the patient often is faced with a choice. They can go to their local cancer center if it's available. They can make the trip to Sioux Falls. Either way, it's a giant commitment of their time, of their family's time, to be able to get this treatment. But we need a radiation oncologist to be present for all of those treatments, to consult when needed. And so we have, what we've done with our eRadiation oncology program is we've installed cameras, speakers, microphones in the linear accelerator treatment rooms. And so this is in a linear accelerator. So in this room where the patient is getting the radiation treatment, there's various cameras positioned on the walls, there's speakers, there's microphones. All of those allow the radiation oncologist, who may be remote, maybe across the state, to consult on this patient's treatment. They can zoom in and see exactly where the radiation is being delivered. They can kind of move around the room virtually and make sure the LINAC machine is positioned correctly. It's basically, they can provide the same quality of care as if they were right there in person with the equipment and with the clinic. And this eRadiation oncology program has been a huge success for us, not only in being able to allow the patients to stay close to home, but also in supporting our radiation oncologists so that they don't have to travel so much to do outreach, so that they have more access to patients. and really providing them with a better quality of life. So the last service I want to highlight is what we call our e-consult specialty care services. And this was the original service, the original telehealth service that started with Avera in the 1990s. And this was born out of need, just as the other ones were. But this particular need was we did not have enough specialists to go around. And so, for example, infectious disease specialists were only located in Sioux Falls. And so we had patients all across our footprint that needed access to these infectious disease providers. Maybe they were an inpatient and they needed an infectious disease consult. Prior to this program, that patient likely would have had to have been transferred to Sioux Falls, and their hospital stay would have had to have been in Sioux Falls because that's where that specialist was. Or maybe it was a patient getting some follow-up care and they're located in Gregory, South Dakota, and they need a visit with the infectious disease provider. Well, prior to the service, they had to get in the car and, drive the 3 to 4 hours to Sioux Falls to see that infectious disease provider. Well, with this e-consult specialty care service, the patient can stay local, whether it's in the hospital or as an outpatient, and they can connect virtually to that specialist using the platform that we have. We use a system called TytoCare, which essentially allows a video visit to happen. Plus, it also offers the specialist the opportunity to use different peripherals to complete an exam on the patient. So, for example, there's a stethoscope so they can listen to heart sounds. There's a camera so they could potentially look at a wound. There's an otoscope, all these different peripherals that they can use to complete the exam on the patient. And so currently our e-consult program has grown to where we have this in over 35 specialties, and we have more than 120 originating sites, and those are the sites where the patient can present for this service. So that's a huge benefit to our patients not having to travel to see the specialist. But from the specialist perspective, it's also a huge benefit for them because they don't have to do as much outreach. They don't have to spend as much time in a car traveling, once a month to Gregory, South Dakota to see those patients in Gregory. They can do it all remotely. We have some specialties like infectious disease where their practice now is about 60% virtual. They see most of their patients using this technology, and then they have about 40% of their patients in the clinic. So this is a more complete list of the different telehealth services that we use throughout Avera. I'm not going to go through and tell the same sort of long story about each one of these as I did the other three, but there are a couple I just want to highlight. E-pharmacy is one I want to mention. Okay, hold on here a second. Sorry, my computer just locked up there. Can you guys still see my screen?
So
Yes.
we can see the current telehealth uses at Avera.
Okay, so just give me a second here. My computer has locked up, so I can't see anything, but I just need to enter in my security code, sorry.
Sure. It probably knows that it's snowing outside and wants to take a rest, but we're patient.
Yeah,
We understand tech issues.
I just think it's, Avera's the security we have on our devices to prevent, cyber attacks and things like that require us to log in every few hours, and I haven't logged in since I logged in this morning. So it's
Sure, makes sense.
Do my due diligence, yeah. All right, so e-pharmacy is a service I want to talk about. So this is a service that we offer through Avel eCare Services. We contract with them for this service, but this is a service just like our specialists or our radiation oncologist, to where there just aren't enough pharmacists to go around. We don't have pharmacists working 24/7 in each of our facilities. However, we need pharmacy in each of our facilities. And so using a service like e-pharmacy allows us to connect with pharmacists to provide that service when we don't have the local pharmacist on staff. The e-NICU service is another great example. Avera has one NICU across all of our facilities. And of course, that's located in Sioux Falls. But as you know, babies can be born anywhere and babies can need NICU services anywhere. So if a baby is born in Wagner, South Dakota, unexpectedly, and that baby needs NICU services, they likely will be transferred to Sioux Falls, but that transfer doesn't happen immediately. We don't have the flying cars to get the baby here, in a matter of seconds. So we use our e-NICU services to where the NICU physicians and APPs and nurses from Sioux Falls can kind of zoom in into that Wagner nursery, and they can not only talk with the staff and see the local staff there and provide, consults with the local staff, but they have cameras that are on the baby warmer so they can actually see the baby to provide the best care possible for the baby, sometimes even allowing the baby to stay in that local facility if it doesn't need to be transferred. Another telehealth service I will highlight is a newer one for us, and it's hospital at home. And the hospital at home service really started around the time of the pandemic, but basically this service allows us to have patients who are hospitalized remain at home. And we use different technology to care for that patient, just like if they were an inpatient in one of our facilities. And so that technology might be things like a video visit with the provider so the provider can round on the patient. We have a lot of remote patient monitoring equipment that's used. So the hospital at home nurse who's located kind of in a hub can monitor the patient's vitals, and those are symptoms, those kinds of things to make sure that we're providing the right care for the patient. There are questionnaires and surveys and ways to get feedback from the patients kind of in real time so we can monitor their symptoms, just like if, the nurse was talking to the patient while they're in the hospital room. So that's a service that uses telehealth in new and innovative ways. And the last one on this list I want to mention is the virtual monitoring and virtual nursing services. These are new for Avera. We're just starting to pilot these. Our first pilot will go live here in May. But this virtual nursing service has really started from a need, and the need is to address our nursing workforce challenges, to really find ways to use a virtual nurse to help support the bedside nurse. It's not to replace the bedside nurse, but to really support the bedside nurse. And so we're using technology that involves artificial learning and artificial intelligence and machine learning in conjunction with sort of video, computer vision, audio, speakers, those kinds of things to really support the bedside nurses with the goal of improving nursing retention, nursing recruitment, reducing nursing burnout, offering nurses more flexibility in how they work their shifts. Maybe they're going to work 2 shifts on the bedside and 1 shift virtually, and maybe that would extend their career. But all using this technology, this telehealth technology, to provide care for patients while supporting our staff and while automating some of the workflows that we have that are more administrative in nature. Great. So I've talked a lot about the telehealth services that we have, and inherent in those services are all of the benefits and opportunities that they give us. So I won't go through this in a lot of detail, but it's important to know that we constantly focus on telehealth on not only the patient care, patient satisfaction, provider satisfaction, but also those other areas, whether it's quality of care or addressing disparities in care or improving management of chronic diseases, finding ways to use telehealth to address those types of things as well. So for example, improvement of management of chronic diseases. One of the things that we learned, especially over the pandemic when we started to do a lot more of those virtual visits, is we can use virtual visits for those chronic conditions where patients need frequent visits or frequent touch points. They don't always have to come into the clinic for that visit. Maybe they come into the clinic once a quarter, but we can do monthly or bi-weekly virtual visits with them for those frequent kind of checkpoints. And that not only improves the overall management of their condition, they're more likely to be in compliance with attending these visits, but also it saves them a lot of time. They don't have to take the 2 hours off work to come into the clinic. It's a lot faster for the provider in many cases as well. Another area, another benefit we're really seeing with telehealth is around mental health and our behavioral health sort of crisis that we have. We do a lot of our virtual visits are in the behavioral health area, and that's been a real lifesaver in many of our communities where we don't have behavioral health providers. A couple other things I can just highlight on here. Patient experiences. I didn't mention this earlier. I think I had a bullet point on one of the slides, but patients like virtual care. It's not appropriate for every situation, but they really like the opportunities virtual care can provide. So we're always looking at feedback from our patients too about the virtual services we provide and about the benefits or the needs that they have. So that's just another opportunity we see with our telehealth services. So we have a lot of benefits. Telehealth gives us a lot of great opportunities. But we do have a lot of challenges with telehealth as well. It's not all rainbows and unicorns. Telehealth, some of the biggest challenges with telehealth really relate to reimbursement and payment parity. It's gotten better over the past few years, but telehealth visits aren't consistently reimbursed the same way as an in-person visit is. And that causes some challenges sometimes. Not every payer pays for a telehealth visit the same way they pay for an in-person visit, and some payers don't pay for certain kinds of telehealth visits. So that's a challenge. The evolving regulations around telehealth has really been challenging, especially the past few years. There's a lot of unknowns related to some of these regulations. With the pandemic, there were a lot of waivers put in place that made telehealth much more doable. There were a lot of flexibilities that really allowed us to practice telehealth or to involve telehealth in our practices. Some of those waivers are going away with the end of the pandemic. Some have been extended for a period of time. We don't really know what happens after that. So a lot of those the unknowns around those regulations make some providers and make some facilities fearful about embedding telehealth too deeply into their practices because they don't know what's around the corner. They don't know if tomorrow this is still going to be allowed or if it's not going to be allowed. So they're a little hesitant. Provider credentialing is another challenge that we have when it comes to telehealth. So when we see a patient in their home, the provider needs to be licensed where the patient is. So when we do a virtual visit, and if the patient is on vacation in Texas, the provider, even though it's a patient the provider sees on a regular basis in the clinic, that provider needs to be licensed in Texas to see that patient who's on vacation in Texas. That's difficult. You know, most providers aren't licensed in all 50 states. It doesn't make sense. They don't want to do that. I don't blame them. And so that makes it challenging, all of the licensing and credentialing that's required for telehealth. Access to technology is getting better all the time, but we have patients that don't have technology in their home or don't have the internet bandwidth in their home to really facilitate things like remote patient monitoring or virtual visits. So that's something we're constantly working with. Lately, there's been a lot of emphasis around HIPAA and how that, the protection of the patient's data, how that is impacted by telehealth. And it's not only that these telehealth platforms need to be HIPAA compliant, but maybe you've read about some of this fairly recently, where if you have a telehealth visit, for example, with a telehealth company like Teladoc, or name your telehealth company, and that visit is for a sore throat, and after you have that visit, you all of a sudden start getting ads on your Facebook feed or your Instagram feed for throat lozenges or something like that, right? So how does that happen? And is that kind of selling of that analytical data a HIPAA violation? So there's a lot of work happening right now in that space related to how telehealth should or should not fall into some of the protections offered by HIPAA and patients' data. There's also some challenges related to prescribing of controlled substances via telehealth as well that can be a challenge for providers. My screens are super slow in advancing here. Prior to the pandemic, telehealth was pretty restrictive on what we could be reimbursed for, at least from the Medicare perspective. So prior to the pandemic, when we talked about the originating site of where the patient is located, there were two kind of criteria, and they're number 1 and number 3 on this slide. So first of all, we could be reimbursed for a telehealth visit if the patient was basically in a rural area. So that means they couldn't have been in Sioux Falls, or they couldn't have even been in Del Rapids, because Del Rapids is in Minnehaha County, which is not considered a rural area. So the location of the patient prior to the pandemic, they had to be in a rural area, and they had to be in one of these healthcare facilities in order for it to be eligible for reimbursement. If you notice this list of facilities, what's not on here is the patient's home. So prior to the pandemic, we couldn't necessarily be reimbursed from Medicare for doing a virtual visit in the patient's home because the home was not an appropriate originating site. So with the pandemic came lots of waivers, which I mentioned were a good thing in allowing us to practice telehealth. And so with the pandemic, some of these waivers that were put in place were things like the removal of that geographic restriction. So patients could be located anywhere in the US, and you would be eligible for reimbursement for that visit. There were flexibilities.
For Chris.
Yep.
Sorry, I totally
go ahead.
was working on a different email. We do have a quick question. What's the definition of rural? So when you say the patient needs to be in a rural location, is it like the HRSA rural where it's basically outside of Minnehaha and Pennington County, or does Avera define that differently?
So this is how CMS defines it. And
Okay.
so the requirements were it has to be in a health professional shortage area outside of a metropolitan statistical area. And so you can go on websites and kind of look this up, but basically it's anywhere outside of Minnehaha or Sioux Falls area, Minnehaha, Lincoln County, and then Rapid City also is an MSA area. So those are the restrictions, and they're really defined by CMS. Mm-hmm.
Perfect. Thank you.
Yep. So during the pandemic, oh, sorry, my slides are going crazy here. The waivers were put in place to remove that geographic location, to also allow flexibilities on when a patient needs to be seen in person, meaning does the patient need to be an established patient of the providers before you do that telehealth visit? So those flexibilities were put in place, saying no, the patient did not have to be established with a provider. There were also many states also waived the licensing requirements for telehealth, meaning I could see if I'm a South Dakota licensed provider, but my patient happened to be on vacation in Texas and wanted to do a virtual visit, I could see that patient virtually in Texas without having to worry about the licensing part of it, because that was waived during the pandemic. Since the pandemic, over the past maybe 9 months or so, there have been some acts or bills that have been put in place that have further defined what's going to happen to all of these flexibilities after the pandemic. The most notable one, or the most recent one that I want to talk about, is the 2023 Omnibus Appropriations Bill. This bill was signed just at the end of last year in December of 2020. And this bill extended many of the telehealth flexibilities through the end of December 2024. So it gave us basically 2 years of all of these flexibilities, which is great. However, it's not all of the flexibilities that were extended, just some of the flexibilities that were extended. And so another thing that's happened recently is it's been announced that the public health emergency will end on May 11th of 2023, so just about two and a half months from now. And with the end of the public health emergency, some of those flexibilities that were put in place for the pandemic will go away. One of them is critical access hospitals, as of May 11th, will no longer be eligible to be a distant site provider of telehealth, meaning the providers in that critical access hospital aren't distant site providers. They're not eligible for that. The DEA had waivers in place, basically allowing controlled substances to be prescribed via telehealth without an in-person examination. Those waivers, unless the DEA makes some changes, those waivers will go away at the end of the public health emergency. There's changes to the way the reimbursements will work for remote patient monitoring and remote therapeutic monitoring that essentially require the provider that's billing the services have an established relationship with that patient prior to providing those services. And if you think about how we operated our hospital at home program, that model won't work the same anymore. So we're trying to figure out what do we need to do to stay in compliance and still offer these services. There are other changes that will go away related to how providers basically enroll the location of where they're providing services. So during the pandemic, we had providers sometimes that worked from home, whether they were sick and couldn't come into the clinic, or they just moved to work remotely like many of us did. So at the end of the public health emergency, those addresses where the provider is physically providing the service, they'll have to be essentially set up as an address associated with that clinic in order to bill for that service. So that's a real challenge we're going to have to work through because realistically, I don't think we're going to want to do that as a healthcare system. I don't think anybody really would. Lastly, there were some waivers that the OCR had put into place during the pandemic that said, hey, the platform that you use for telehealth, it doesn't have to be HIPAA compliant. So that allowed providers to use things like FaceTime or Skype to do those telehealth visits. On May 11th, those platforms are not HIPAA compliant, so they won't be able to use those anymore. There are flexibilities, though, that, as I mentioned, are extended through the end of December 2024, which is a good thing. What happens to them afterwards, we don't know yet, but we're all going to be working with our legislative bodies to really help push our telehealth agendas to make sure these flexibilities and things like payment parity really start to become a permanent part of the way we offer healthcare. One of the flexibilities that does stay through the end of 2024 is the location of the originating site, basically the location of the patient. It will continue to be anywhere the patient is in the US. They can provide telehealth services to the patient. So what does all of this mean for the future of telehealth? There are a lot of benefits to telehealth. The technology is rapidly evolving. The regulations, they're regulations, right? They're evolving. They're a little unknown. But what all of this really means is, I don't know what it means for telehealth. I wish I had a crystal ball. What I do believe and what I see happening in the industry is telehealth is here to stay. There's new technology evolving all of the time that really is super exciting, and it's going to give us new opportunities, new way to deliver care, especially to our patients in our rural areas. One of the things I've read is that telehealth and virtual care won't be here in 20 years. It will just be health and it will just be care, right? Telehealth won't be something special. It won't be something different. It just will be part of the care that's delivered to patients. This whole Internet of Things and all of these sensor networks that are now available to, whether it's tracking a patient's vitals or whether it's using, some of the computer vision that we're using for our virtual nursing project, for example, being able to utilize all of the data that's gathered from those sensors and really applying machine learning and artificial intelligence on top of it to improve productivity, that is really, I think, going to take off in healthcare, specifically in the areas of telehealth. I see a lot of opportunities there. I'm sure you've all been reading about these chatbots, these AI chatbots that are out there that, Chat GPT, which I read an article on it the other day. I found it truly frightening, but also really fascinating. But that has so much potential in using a chatbot like that with those deep learning algorithms to really help engage patients, to provide tools for our healthcare providers. So I see a bright future for telehealth, especially related to the technology that is available for us in the near future. Pretty soon, we're going to be way beyond whatever the Jetsons were projecting 100 or 60 years ago. So I just want to close today with a couple of quotes from some of our leaders and providers within Avera about what telehealth means to them. And so this first one is from Brian Slava, and Brian is the CEO of the hospital in Wagner, South Dakota. And Brian said, telehealth or telemedicine has such potential for communities similar to ours and also to large urban communities. Access to expertise at the push of a button improves patient outcomes, saves lives, saves healthcare dollars, and makes for happier providers. Dr. Figuera, who is a radiation oncologist at Avera, he said, we have developed a workable system in which Avera radiation oncologists throughout our footprint collaborate to cover multiple sites. In addition, we can back each other up for vacations, training, or conferences. This helps enhance the quality of life for physicians in a specialty where it can often be difficult to get away. Dr. Papadopoulos is a urologist in Mitchell. He's an Avera urologist. He said, since the outset of COVID-19 and all of the restrictions that came with it, we have effectively incorporated virtual visits in our urology practice. Those have made continued and timely patient care possible. They are adequate for the majority of patients and are very convenient for patients, especially elderly ones or patients from long distances that do not have to travel for their visits. And the last quote I'll share with you is from Rhonda Waring from our Avera at Home part of Avera. She has said the virtual care nurse assessment process has been life-saving. An obstetric patient developed a sudden change in respiratory symptoms, and through a virtual nurse assessment was found to need emergent care. Following an ambulance transfer to the hospital, a healthy baby was delivered and mom's respiratory status improved. So these quotes really illustrate why we offer telehealth and why I really believe that telehealth is here to stay, and it will just keep growing not only within Avera, but with healthcare across the nation. That is all I had to offer tonight. I talked a lot, so I'm really happy to answer any questions anybody has or to talk in detail about anything more if there's additional detail needed.
Sure. So feel free to hop off mute if you are in attendance and have questions. Chris, I think the biggest thing that stayed with me, and it goes back to kind of COVID, the AHEX had a grant to do some telehealth training or some virtual training opportunities. Michaela focused on the mental health side, and I focused more on the student access side. And we worked with Avera Parkston, and she connected us to the Avera eCare in Sioux Falls. Just a push of a button. It's extra oversight. It's assistance of, hey, you might have missed something, or have you thought about this? It's a collaborative effort that a lot of our rural communities, especially obviously here in South Dakota, have. So I just want to say I've been fascinated learning about this, and that's my biggest takeaway of a lot of the people we've talked to have said it's more of a help than a hindrance.
Yeah, for sure.
Or you can type your questions in the chat. The rural one was great because the definition Michaela and I use for rural, a number of our grants is a little bit different sometimes for different organizations. Perfect. Michaela, did you have any questions that popped up on your side?
Not on my side. It looks like. Yeah, no.
I mean, the one other thing I think I would leave our students with of, you think of your Apple Watch and some of the functions our phones have in our Apple Watches or whatever watch you use, and how realistic it is and how beneficial. One of the stories I think of is your Apple Watch can catch, hey, you need to breathe, or your heart rate is increasing. You might need to keep a track of that. And those are things you can go talk to your patient, or you can talk to your physician or provider about as the patient. But even as future providers, you can ask your patients those of, have you noticed anything weird? I'm seeing you're wearing an Apple Watch. It's kind of that useful technology. Why not use what you have? And I think a lot of this telehealth stuff, it will be changing to more, like Chris mentioned a couple slides ago, of more in practical use or daily use. It'll be termed healthcare and not telehealth. So just some thoughts. Well, Chris, if we don't have any other questions, students, if you have questions listening to this or even on now, feel free to shoot Michaela and I an email. We'd be happy to connect you back with Chris as well. Michaela, I'll let you finish up the last few things.
I had a quick
Oh,
question.
sure.
I guess beyond and maybe Chris, maybe you only know for Avera, but what are other telehealth uses that you've heard about that maybe Avera is in the process of implementing, or just they haven't yet implemented, or that you've just heard about in other health systems?
Sure. I think, you know, I think there are a lot of different telehealth uses, you know, whether it's telehealth related to a certain specialty like neurology and stroke care, and being able to provide some of that stroke care kind of urgently and for patients when needed. You know, there are a lot of things like that happening. I know that Avel eCare has recently signed a contract with, I'm not sure exactly who exactly, but they are providing telehealth services to EMS, you know, ambulance companies here in South Dakota. So they can basically remote into the ambulance to provide, you know, sort of that triage instant care, you know, while the patient's being transported. So I see things like that happening a lot. I think this whole virtual nursing thing that I mentioned that Avera is starting to do, I've probably talked to 20 healthcare systems, large healthcare systems across the country that are going on this same journey that Avera is, in being able to provide sort of this virtual nursing services for the exact same reason that Avera is. And one of the things I think that is unique about at least the companies I've seen that are offering some of these services is really the layering of the AI and the machine learning on top of it. And so it's not just a video visit, or it's not just a camera in the room that's watching the patient, or it's not just, you know, the data coming off the monitors in the ICU that's being fed for a person to view. It's really the layering of the artificial intelligence on top of it. So the computer can start to do some of those functions, can start to pick up on some of the information that is gathering from these different types of sensors. So I see that happening a lot too. I think the sky's the limit with telehealth. And I think, you know, I was just going to ask, do you have an idea on how telehealth can be used? Because oftentimes too, that's where some of these grow. So.
Perfect. Great question, Sam. That was awesome.
Well, with no other questions, thank you so much, Chris, for taking time in sharing your expertise in telehealth for these students. Just please remember, students, to submit your hours for tonight and submit any hours you might have that you're waiting to submit. So, Corinne, do you want to add anything?
Yeah, that was it, Chris, again, from both Michaela and I and from our students. We really appreciate your expertise and your time with us this evening. And we'll connect with the rest of our students here in the future.
All right, thanks, everybody. It was great to talk to you.
Thanks.
Thank
Have a good
you.
night.